So here's a quick table to just point out some of the main differences between the case control and cohort study. So as you already know, case control starts with the disease and then looks at exposure, whereas the cohort starts with exposure and looks for disease. Case control is good for rare diseases, whereas the cohort is good for common diseases or risks associated with rare exposure. And we're going to talk about this in the rest of the video. Case control is better for longer follow-up, so diseases that take a long time to develop, because for cohorts we get dropout, which increases bias. The longer you follow people up, you lose track of them. Case control studies are also more vulnerable to biases like selection and recall biases. And finally, case control are less expensive because you're putting the study population together after the disease is developed, and the cohort you have to have enough people so that you get enough disease developing in order to study the relationship to exposure. So those are some of the things to remember that differ between cohort and case control, and we're going to focus now on the types of situations where a cohort study makes more sense. Okay, so there are two types of cohort study, two situations where a cohort study makes the most sense, or makes sense to do. So one is for common exposure, so exposures that are true across a lot of people, so smoking, high blood pressure, things like that. And so examples of cohorts that have been developed are ones that focus on a single geographic population. So I'm going to tell you more about the Framingham heart study that was done with, try to include the entire population of Framingham, Massachusetts, which is a smallish town in Massachusetts, in the cohort. And then there are also studies looking at single populations of professionals. So for example, the Nurses' Health Study is a really big one. And a lot of work has come out of that, so they just followed nurses in the study. So the other type of situation in which a cohort study can be helpful is, ironically enough, the opposite. So when you have a rare exposure, you can create a special population, a special cohort to study that rare exposure, the consequences of that exposure. And so in this case, we're talking about asbestos workers or retired football players, looking at mild traumatic brain injury. So you're not going to look at that throughout the whole population, but you would pick a cohort that where you might expect to see that outcome more frequently. And then rescue workers from 9/11, for example, there's a lot of work looking at respiratory illness that developed among that population. So you can limit your population in a cohort to one that was exposed to a particular environmental situation or something that you're interested in studying. So now I'm going to give you two examples, one of each of these types of cohort study. Okay, so the first one is the Framingham heart study. So this was started in 1948, which is 65 years ago. And it's been going on since 1948, although recently they just cut the budget of this study by 40%, which is pretty dramatic after the whole sequester situation. But this was sort of instigated by looking at this change in deaths due to cardiovascular disease. So this shows from 1900 to 2008, and you can see that by about 1950, it was already apparent that there was a dramatic increase in these deaths occurring in the United States, which actually kept going up and now finally is starting to go down. And actually that's probably due to the work that was done with the Framingham heart study. So the Framingham heart study recruited 5,209 men and women from Framingham, Massachusetts, and these were middle-aged adults. And every 2 years they did physical exams and lifestyle interviews. Because you have to remember, at this point they didn't know, the question was what causes heart disease, and at this point they didn't know what kinds of things might be related to heart disease. So they had to do, collect lots and lots of data on possible relevant exposures so that they could ultimately identify what factors are related to the development of cardiovascular disease. So these pictures show the original building in Framingham where they had the offices, and then some pictures of early doctors. So as I said, this started in 1948, so it's 65 years old at this point. And by this point, they've enrolled 3 generations. So they enrolled the first group of people, their children, and now they have the grandchildren of the first cohort in the study. And so now they're able to look at genetics and actually even natural selection. So the Framingham Heart Study basically put preventive medicine on the map, and as this quote shows by the current PI, or head of the Framingham Heart Study, Framingham changed the focus of healthcare from treating sick people to trying to prevent healthy people from getting sick. So the whole idea of risk factors did not exist before the Framingham study, and these are just some of the milestones. You don't have to remember these, but it's just to point out how significant this study was in our current understanding of cardiovascular risk. And of course we know that cardiovascular disease is the main cause of death in the United States. So this is absolutely critical to understanding health risk generally. So cigarette smoking, this was a study that showed cigarette smoking is a risk factor, cholesterol, blood pressure, physical activity, obesity, menopause, some psychosocial factors. This is the origin of the Framingham risk score, which is even now what's used to predict risk of CHD in asymptomatic adults, and continuing to show a lot of evidence about the heritability of various diseases and outcomes. So this is a really important study, obviously, and it's the cohort design that really enabled us to understand these causes of heart disease. And obviously you can't do a randomized controlled trial if you don't even know what the exposures are that you're looking for. So this is sort of a really great example, I think, of science in general, but certainly of the cohort design. And there's been lots of cohort studies since then. So the next study we're going to look at is a study looking at a particular exposure, a rare exposure. So this is the NCAA concussion study. And the question is about the cumulative effects associated with recurrent concussion in college football players. So 2,905 players were enrolled in the study over 3 football seasons, and any concussion that they had, or actually any head injury they had, was followed to track symptoms, and then all concussions were identified by the trainers. So the researchers asked all the players who were enrolled in the study to report the number of prior concussions they'd experienced before the cohort began. And then they tracked the incident concussions that occurred over the course of the study and looked at the relationship between those. So here are the results of the study. So over here we have the number of previous concussions that had been reported prior to the onset of the cohort, and then this is tracked over, I believe it was 2 years, how many incident concussions were experienced by as a function of the number of prior concussions. And so and this is the number of athlete exposures to concussions, so the number of times, I think, practice and games that they were, exposed to the possibility of having a concussion. And so then this is the concussion rate per 1,000 exposures. And this is the rate ratio, which is just the relative risk. And this is the ratio adjusted. And that's adjusted for BMI, years of football experience, division, and playing position. So just a couple points here. So you can see that there's level of exposure here. So it's not just exposed or unexposed. So the rate ratio or relative risk of the group with one prior concussion is this rate divided by the rate of unexposed. And similarly, for the people with two prior concussions, it's the rate, the incident rate, the rate of concussion in this study over unexposed again, and then same here. So the rate for people with greater than or equal to 3 concussions is this rate divided by this rate to get this rate ratio. And so you can also look at the confidence interval and then compare, and really we want to be looking at the adjusted rate ratio because it's adjusted for all these possible confounding variables. And these are things that the researchers felt might be more likely to be true of one exposure group than another, and also related to the outcome. And so looking at the confidence interval here, we see that 1.4, so people with one prior concussion may not be different from no concussions because 1 is in the confidence interval. But then once you get to either 2 or more concussions, you see a really much higher rate of incident concussions in this group relative to those who had not suffered that many prior concussions. And but there is no difference really between 2 or 3 or more, so there seems to be kind of a threshold happening here. Now you can always say if you had more participants, the confidence intervals might shrink, and therefore you might find a difference between these levels. But anyway, so that just gives you an example of a study looking at a select cohort that was selected for its exposure to a particular risk.